Imagine two patients. Both are breathing 20 times per minute. Both have a tidal volume of 500 millimeters. Both appear to be ventilating normally. Yet, one patient has a normal PaCO2 and the other one is becoming progressively hypercapnic. How is that possible? The answer lies in one of the most misunderstood concepts in respiratory physiology: dead space. Not every breath contributes to gas exchange, not every breath removes carbon dioxide, and not every patient who is breathing is actually ventilating. Today we will discuss ventilation, physiological dead space, and work of breathing, the concepts that explain why patients tire, why COPD patients retain CO2, and why some ventilated patients still die from respiratory failure despite receiving apparently adequate tidal volumes. Now, what is ventilation? Most people use the words breathing and ventilation interchangeably. Physiologically, they are different. Breathing simply refers to the movement of air in and out of the lungs. Ventilation refers specifically to movement of fresh air into the alveoli where gas exchange occurs. This distinction is critical. A patient can be breathing vigorously and still have inadequate ventilation. Conversely, a mechanically ventilated patient may have no spontaneous breathing but excellent ventilation. To understand this, we need to define minute ventilation. Minute ventilation is the total amount of air entering or leaving the respiratory system every minute. Mathematically, minute ventilation is equal to respiratory rate into tidal volume. If respiratory rate is 12 breaths per minute and tidal volume is 500 millimeters, minute ventilation equals 6 liters per minute. Most students stop here. The problem is not all 6 liters actually reach alveoli. The concept of dead space. Imagine taking a breath. Air first enters the nose, then pharynx, then larynx, trachea, bronchi, bronchioles. Only then does it reach the alveoli. The conducting airways do not participate in gas exchange. No oxygen enters blood there. No carbon dioxide leaves blood there. These airways simply transport gas. The volume occupied by these structures is called anatomical dead space. In healthy adults, anatomical dead space is approximately 150 milliliters. Now consider a normal tidal volume of 500 millimeters. The first 150 millimeters never reaches alveoli. Only 350 millimeters participates in a gas exchange. This immediately explains why shallow breathing is inefficient. Imagine a tidal volume of 200 millimeters. If 150 millimeters remains in dead space, only 50 ml reaches alveoli. Most of the breath is wasted. This is why rapid shallow breathing is often associated with respiratory failure. Now, alveolar ventilation. The air reaching alveoli is called alveolar ventilation. This is arguably the most important ventilation parameter in physiology, because carbon dioxide elimination depends on alveolar ventilation, not minute ventilation. Mathematically, alveolar ventilation is equal to tidal volume minus dead space divided by respiratory rate. Now notice something important. Dead space is subtracted before multiplication. This means increasing tidal volume is usually much more effective than simply increasing the respiratory rate. Let's compare. Patient A, tidal volume is 500 ml, respiratory rate is 12, dead space is 150 ml. Alveolar ventilation would be 4200 milliliters per minute. Now patient B, tidal volume is 250 ml, respiratory rate is 24, minute ventilation is identical. But alveolar ventilation becomes 250 minus 150 into 24 to 2400 ml per minute. Despite identical minute ventilation, alveolar ventilation is dramatically lower. This patient will retain carbon dioxide. This explains why patients with rapid shallow breathing often deteriorate despite appearing to breathe quickly. Now, things become more interesting. Not all alveoli are functional. Some alveoli may receive ventilation but no blood flow. These alveoli cannot participate in gas exchange. From a physiological perspective, they behave exactly like dead space. This is called alveolar dead space. Examples include pulmonary embolism, severe shock, low cardiac output states, certain ventilated settings. Physiological dead space equals anatomical dead space plus alveolar dead space. In healthy individuals, alveolar dead space is minimal. Therefore, physiological dead space approximately is equal to anatomical dead space. In diseases, physiological dead space may increase dramatically. Now, one of the classic questions in physiology is, how do we measure physiological dead space? The answer is the Bohr Equation. That principle is simple. All expired carbon dioxide comes from functioning alveoli. Dead space contributes virtually no carbon dioxide. Therefore, dilution of expired carbon dioxide reflects the amount of dead space present. The equation is physiological dead space volume is equal to tidal volume into PaCO2 minus PeCO2 divided by PaCO2, where Vd dead space volume, Vt tidal volume, PaCO2 arterial carbon dioxide tension, and PeCO2 is mixed expired carbon dioxide tension. As dead space increases, expired CO2 becomes diluted. The difference between arterial and expired CO2 widens. The calculated dead space fraction increases. In pulmonary embolism, blood flow to portions of lungs suddenly stops. Ventilation continues, perfusion disappears, dead space rises dramatically. Patients compensate by increasing respiratory rate. Despite this effort, carbon dioxide elimination becomes inefficient. Similarly, in severe shock, reduced pulmonary perfusion can increase dead space. This is one reason critically ill patients may require mechanical ventilation despite relatively normal lung parenchyma. An elevated dead space fraction is also associated with increased mortality in ARDS. Modern intensivists often use dead space measurements to assess severity of illness. Now, let's discuss why breathing becomes exhausting. Under normal conditions, breathing requires surprisingly little energy. Only about 2 to 3% of total oxygen consumption is devoted to respiratory muscles, but this can increase dramatically during illness. Work of breathing is defined as the energy required to move air into and out of the lungs. 3 major factors determine work of breathing. First, compliance. Stiff lungs require greater pressure to achieve the same volume. ARDS is the classic example. Patients appear to fight for every breath because each breath requires enormous effort. Second, airway resistance. Narrowed airways increase resistance to airflow. Asthma and COPD are classic examples. Patients generate tremendous pressure simply to move air through obstructive airways. This explains prolonged expiration and use of accessory muscles. Third, increased ventilatory demand. Sepsis, metabolic acidosis, fever, exercise all increase carbon dioxide production or oxygen demand. The respiratory system must work harder to maintain hemostasis. Watch a patient with severe COPD. They recruit sternocleidomastoids, intercostals, abdominal muscles. They sit forward in a tripod position. Why? Because their work of breathing has become enormous. Eventually, respiratory muscles fatigue. Once fatigue occurs, carbon dioxide rises rapidly and respiratory failure develops. This is often the moment when non-invasive ventilation or intubation becomes necessary. The ventilator does not merely improve gas exchange, it unloads exhausted respiratory muscles. Breathing and ventilation are not the same thing. Minute ventilation does not equal alveolar ventilation. Dead space represents ventilation that does not participate in gas exchange. Physiological dead space equals anatomical dead space plus alveolar dead space. The Bohr Equation allows estimation of physiological dead space. Work of breathing increases when lungs become stiff, airway becomes narrow, or metabolic demands rise. And perhaps the most important clinical lesson: a patient may be breathing hard, breathing fast, and moving plenty of air, yet still have inadequate alveolar ventilation and progressive respiratory failure. That distinction is at the heart of critical care medicine.